to the patients that we have here. So Dr. Lula, you want to start now? Okay. Go ahead. So let's make sure that we understand the patient that we have here. We have Miss. Can you hear me now? Can you hear me now? Okay. So we have Mrs. Eureka, and she has Helicobacter pylori in her stomach, and we are treating her with IV curcumin, and hopefully this curcumin will get into her stomach and kill the guts bacteria, which is the Helicobacter pylori, which is causing her some problem with her GI function. And it's very important to get rid from this Helicobacter pylori because chronic infection can lead to ulcer, and some studies they say it can lead to cancer. So we take Helicobacter pylori seriously, and we need to eradicate it. Now you can use the natural stuff, which is curcumin as antibiotic, but I also recommend triple therapy, which is antibiotics, amoxicillin, clarithromycin, and antacids. I think that will work, and then you maintain the treatment with curcumin. And now we're doing it IV, and we'll give her blue light to activate the curcumin. Then we have other two patients with they have history of colon cancer and has metastasis, and we are giving them ICG and the cyanide green as a photosensitizer, and we're also giving them curcumin, and then we're going to activate it using a laser. We're going to the way that we can help those patients, especially if they have some metastasis in the lung, we're going to introduce a catheter through their nose and goes to the esophagus, so the light will be irradiated from inside and it will get to the lung from inside. This is a new method that I invented, and I think it is the best way to get the light deeper inside and get into the lung. It's not practical to do it through the throat because it's very irritant and you cannot do it for a long period of time. It has to be through anesthesia, general anesthesia to do that. And I see it's not practically feasible or convenient because we need the light to stay there for a long period of time and doing it on a daily basis. So that can be done intranasally without any problem, without any reflexes that we experience when we try to do it through the mouth. So we're going to do that after 4 hours. So we did this medications, circulate the body, settle the cancer, concentrate the cancer, and then we radiated the lung cancer, the metastasis with the esophageal, and possibly we're going to move it all the way to the stomach. So if there's any liver metastasis, we can get the light there as well. And we're going to use infrared, and infrared can have almost like 5 centimeter depth of penetration, so it can reach out to the lung and to the liver and activate the ICG and use the apoptosis by increasing the free radicals. We're also going to do catheter through the rectum. And yes, so we're going to get the through the rectum and radiate the light. So if there's any remnants of polyps or cancer left there, we can activate and do cyanide green that concentrate into any metastasis or anything that's being left into the rectum for patients. Because I think they start with rectum cancer and then metastasize into the lung and the liver. So we will get the light deep from inside. At the same time, I recommend when you do the laser, it's going to do also oxygen therapy. Why? Because the mechanism of photodynamic therapy is basically you have to have light and photosensitizers and oxygen, right? So the photosensitizer, they get activated with light, they excite electrons, and the electrons will be picked up by the oxygen, and then the oxygen becomes free radical, and then the free radical will eat the cancer or induce apoptosis and cause cell death. So it's exactly when you are turning fire, what you need. You need oxygen, right? And you need that star of light to turn the fire. So the same thing, give the patient laser and oxygen. It's better to give them at the same time.
So how do you give the oxygen? Is it
You can do it IV, oxygen. There is a system here where you can do oxygen IV. And also we have ozone. So I prefer doing it both at the same time. So you get the oxygen and the light, because what kills the cancer is the free radicals, which is coming from the oxygen. And if you add the oxygen, it will increase the efficacy of your photodynamic therapy and make it more effective. I will just give you a brief understanding of what's laser, because I hear Dr. Zona, she wants me to talk about what is laser itself. And simply laser, it's light, it's electromagnetic wave. It's the light that's coming from the sun. And we know from the sun there is visible light, and then there is infrared, and there is ultraviolet, right? So the visible light, where all the colors that we see, the visible light, the wavelength is from 400 to 700, right? And when it goes above 700, we call it what? Infrared. And if it goes above, we call it far infrared. And if it's more, we call them what? Microwaves, and then radio waves, right? As more as when the length of the waves increases, we change the name. But they are all electromagnetic waves. What we can see, our eyes can only see from 400 to 700 nanometer. Above that, we cannot see, we call them infrared, far infrared, microwave, radio. And below 400 is the ultraviolet, and then you have the X-ray wavelengths, which is below 400 to 200, and below that also X-rays. They are invisible, we don't see them, right? That's when you do X-ray, you don't see them. But X-ray have good penetration. Ultraviolet is not that much, but when it goes to the visible light, the yellow, the green, and the blue doesn't have much of penetration to the skin. But when it gets into the red, you have like 1 to 2 centimeter, possibly 3. But infrared, it has 5 centimeter, so it has better penetration. That's the reason why we use ICG, because we can get to the deeper metastasis and deeper cancer through activating the indocyanine green using infrared light. I am the one who originated the idea of translating into clinical first, and then Dr. Weber adapted the protocol, and he started applying it on the patients, and 3 weeks is on the patients, ICG, and after 3 months it's now all over Germany University, and it's become a common practice for most of them for doing photodynamic therapies, but I'm the first who translated into clinical. Now I'm thinking about doing methylene blue, because methylene blue has the best attraction to the cancer. Methylene blue, methylene blue, it has the best attraction to the cancer or any inflamed tissue. So I'm working on developing protocols on methylene blue, and we're going to have it here in Dr. Luna practice. We will have a lot of methylene blue for photodynamic therapy. And why for the methylene blue? Because in addition, it has the photodynamic effect on killing cancer and infection, like leishmania, Lyme disease, all that. We can use methylene blue with red light, 660. Also, methylene blue has other good functions. It has antibiotic, anti-inflammatory, antioxidant, analgesic, anticonvulsant, so it has many other applications. Just recently, there is a company in the United States that are using methylene blue to treat Alzheimer's disease. They're using a big pharma also. A company is using methylene blue capsule to detect early detection of colon cancer. So they take it, it stains their polyps, and when they do the endoscopy, you can easily visualize those polyps and remove them. So those are two products, Big Pharma is producing it, and it's going to be in the market soon. So that's the concept of laser. Laser basically it is the light that's coming from the sun. But we determined that certain wavelengths of this light helps the body or the biology. And so, according to the publication, we find out the infrared 810 nanometer and the red light 660, they help to the mitochondria, it helps to improve the function of mitochondria, release the nitric oxide. So those are two wavelengths that we studied and we know that it works. So this is the same thing when we're extracting nutraceutical from the food. We're getting the good things out of it. We're also extracting wavelengths of light that benefit the body. So we find the infrared and the red and also the blue light works on the hemoglobin, as we saw the animation there, 450 nanometer. They help in increasing nitric oxide and buffering the redox and increasing the mitochondrial function. We are extracting, we can say, certain wavelengths of light that benefit, and we concentrate it and we produce what we call the laser, and it's more a concentration of those light, polarizing it, and we're using it for helping the function of the body, especially the mitochondrial function. So those are the concept of laser. So we call this field photoceutical versus nutraceutical, right? So when we extract the nutrition from the food, we call this one nutraceutical. And light, we call this photoceutical, photomedicine. And we find out that light also helps stimulate the stem cells, as we explained. It increases the physiological free radical and take the cells to divide, the stem cells. So we call this field photoregenerative medicine. So let's go back to, again, let's go back to photodynamic therapy. And that's what we are doing currently on these patients. We are injecting them with the photosensitizers, ICG, curcumin, and tomorrow we're injecting them with methylene blue, and possibly we're going to inject them with doxorubicin, low-dose chemotherapy. So they have 4 photosensitizers. And so we use low-dose chemotherapy, and doxorubicin can be activated with blue light. So it's photoactivated chemotherapy, low-dose chemotherapy. Not just that, we also taking those photosensitizers of drugs and turn them into nanodrugs. So everything that we do, it's going to be nanodrugs. What is the difference between drug and nanodrug? What we know, most of the drugs out there, they are naked. They don't have any delivery mechanism. Now we are loading it into nanoparticles to have better bioavailability, better absorption, better concentration into the cancer. And that we call this target therapy, where your cancer drugs goes mainly to the cancer instead of going all over. So traditional cancer therapy, most of them, they are naked chemotherapy. They go all over, good tissue and bad tissue, and damage both, right? And that's why you get hair loss and you get all those liver problems and jaundice and all that stuff, which is a side effect of the chemotherapy. But once we turn them into nanodrug, the nano delivery helps to deliver those drugs into the cancer tissues, which are the leaky tissues. They trap there and they concentrate more of the cancer than the normal tissue, which helps to turn this therapy into more to target chemotherapy. So all the drugs that we have, whether it's photosensitizers or their chemotherapy, they are nano drug. And this field of medicine is called nanomedicine. Big Pharma is now changing or transforming all the drugs out there, even antibiotics, anti-cancer, even cardiovascular drugs, into nano drugs. That's the Pfizer what they're doing, but that will take another 50 years for them to produce it, all the clinical trials. I think Dr. Luna and I, we're going to produce it tomorrow, from the compounding pharmacy, so we would have all those nano-nutraceutical, nano-drugs available for our patients. We don't want to wait for another 50 years. We know it's working and it's effective, and we don't want to go through that 50 years of development. So it can be done easily in South Africa, and also it can be done in Germany. In the United States will be very hard to do it, but I have ideas to compound nanoparticle in the compounding pharmacy using the regulation of the compounding pharmacy. So yes, I was able to go around it, and possibly even in the United States we will be doing nanomedicine from the compounding pharmacy. Again, those nano drugs, like let's say the ICG, the curcumin, they concentrate, when you inject them, they concentrate into the cancer, and then we give them that light. For the ICG and the cyanide, it activates by infrared. For curcumin, we activate it with blue light. Tomorrow we will have methylene blue, which we can be activated with red light, 660 nanometer, and doxil, we can activate the same light that we use for curcumin, which is 400 nanometer. So those drugs will concentrate mainly into the cancer tissues, and then we radiate them with light. What would happen? Those photosensitizers, the electrons will be excited by the light, right? And it's called the excitation. And Dr. Shapiro, when he comes, you will see a wave of excitation of those photosensitizers. He has a diagnostic testing that can test the waves and can detect those. And then when the electrons is being excited, they will be picked up by the oxygen. And when the oxygen is reacting with this electron, they become free radicals, and you will see another wave in Dr. Shapira's system that shows that yes, the photodynamic therapy is working, and now you have the free radicals, and those free radicals will induce apoptosis and kill the cancer, right? So now we have a diagnostic test to monitor the efficacy of the treatment, knowing that it's working and it's effective. And I think Dr. Shapiro will come after me and explain his system, his diagnostic system, which will help in early detection and monitoring the efficacy of the treatment. Again, I am doing a lot of methylene blue to treat a lot of cancer infection. We have very good results from the publications that's already out there. My father has hyperphalangeal squamous cell carcinoma, and also he has skin squamous cell carcinoma. And I was able to eradicate the squamous cell carcinoma of the skin completely. And we have the picture before and after. This is the squamous cell carcinoma. I put methylene blue on it. The methylene blue attracts to the cancer tissues than the normal tissue. They get inside and they have a tendency to concentrate in the mitochondria of those cancer cells. Any area where there's pathological free radicals, the methylene blue, they sticks on it. So inflammation, cancer, anything that's inflamed, the methylene blue sticks on it. And then you radiate with red light, many sessions, and eventually what will happen, you induce apoptosis and you eradicate the cancer as you see it here. Complete eradication of squamous cell carcinoma. You don't need that big surgery of cutting all the margins and big lesions, and that's really a disaster for the patient. We were able to manage it painlessly with photodynamic therapy. And publications, a lot of publications out there. As I said, if you want to do any protocol, the protocol has to be supported by publications. So all my protocols, they're backed up with publications. And so for hyperphalangeal squamous cell carcinoma, what I did, we used two methods. One is giving the patient methylene blue orally, and it stains the hypopharyngeal cancer. The other option we did is we inject into the cancer, throw them out, and me and Dr. Weber were able to get it there, and we inject methylene blue, doxil, and ICG, three of them inside the cancer, and then I have a fiber optic of red, light, infrared, and blue through the nose, and it goes into the hypopharyngeal. You can see the light coming out from his throat, activating all those photosensitizers, those chemotherapy, which is doxil, and it did help him improve the swallowing. And I don't say eradication completely because we did only maybe 2 months of treatment. But in order to eradicate cancer with this method, it may take 3 months, 6 months, even 1 year. So it is slow, it's effective, but it's not 1 week therapy or 2 week therapy. So a lot of patients say, you know, I did this and I spent a lot of money and I don't get. No, there is improvement. You slow the process of the cancer, yes. You improve the survival rate, but if you want to get into eradications, you need to continue doing it. And we increase the dose of those photosensitizers with time. Possibly we can change to other wavelengths, microwaves with cisplatin. That's another option. So we will find a way to go around any resistance of those cancer cells, stem cells. But if you doing it 2 weeks and you stop, what would happen? Those cancer stem cells can grow and they become resistant to the medication you have. So it's very important to continue hammering those cancer stem cells. And it's very important to give polyphenols or curcumin because they will help to increase the sensitivity of the drugs. Like if you give doxorubicin or you give Doxil or you give all those photosensitizers, the curcumin helps to increase the sensitivity of the cancer stem cells and the cancer cells to those free radicals and make it and then use doses. How many time left? 5 minutes. Okay. So this is leishmania. Patient with leishmania. We did methylene blue on the leishmania, it sticks into leishmania, and then we irrigate with light, red light 660, and we're able to completely eradicate leishmania. Now leishmania, they use all this anti-cortisol, anti-parasite drugs, which has toxic effect on the liver. Methylene blue is less toxic, it's effective. You can do it IV and topical to get rid even from the leishmania in the blood that circulates, and also the local lesion. You can treat malaria with it, with methylene blue. HIV also it helps. So we have all these publications about chronic infections using methylene blue. Okay, so what's going on with Big Pharma? As I said, what I'm doing currently is the Big Pharma is doing it, but it will take 50 years for them to finally develop the products. But me and Dr. Luna will start doing it from tomorrow and today. We'll be developing all those nano drugs and providing it to the patients. So the compounding, pharmacy, regulations, and arena or cover. So the global nanomedicine market is anticipated to reach 350 billion by 2025, according to the new report by Grandview Research. Development of novel nanotechnology-based drugs and therapies driven by the need to develop therapies that have fewer side effects. So all those chemotherapy that we use, the traditional, they damage both the cancer cells and normal cells, and it gives all the side effects: hair loss, liver toxicity, falling teeth, all those problems that we have. We can minimize it by loading this drug into nano because they have more tendency to reach or target the cancer cells. So it has fewer side effects and that are more cost effective as well, especially if we can develop it here in South Africa, than the traditional therapy, in particular for cancer. Application of nanotechnology-based contrast-free agents for diagnosis and monitoring the effect of the drug is also attributed to drive growth in the coming years. And that's what Dr. Shapira is doing. He is developing that system to diagnose cancer, early detection of cancer cells using ICG, because they concentrate into the cancer cells and then he irradiate them with light, and he was able to detect that light that emitted from it by the system and say, hey, there is cancer and still in this patient. So he's using ICG. I will be recommending doing methylene blue system for using methylene blue instead of ICG, or use both to help to diagnose cancer. As per WHO, fact sheet, cancer is found to be one of the major causes of mortality and morbidity worldwide, with approximately 14 million new cases in 2012, 8.2 million cancer-related deaths. Those demands for nanomedicine, so That's the future. In order to curb such high incident rate, is expected to boost market progress during the forecast period. So this is what we are doing. What we are doing lines up with what the big pharma is going to do, but the result of big pharma will take 50 years. We're going to do it from tomorrow. Solutions such as nano formulation, that's what I'm doing. I'm doing nano drugs, nano chemotherapy, nano photosensitizer, even nano nutraceutical, nano antibiotics, nano cardiovascular drugs with target release of tailor-made pharmacokinetics, nanoparticle for local control of tumor in combination with radiotherapy, phototherapy. So there is also drug that sense, we call them radiosensitive drugs, or microwave-sensitive drugs, like cisplatin is an example. And functional nanoparticle for targeted in vivo activation of stem cells. We're also extracting exosomes from the stem cells, and we use it to stimulate the endogenous stem cells of your own body. Are anticipated to drive the research and development, consequently resulting in revenue generation in the coming years. So that's the future. Okay, so how much I have? Are we done, or you want me to finish up these?
No, we're done. I think we can go for questions and answers now.
Okay. Any questions?
The oral administration of the drug, is it as effective as the intravenous?
For methylene blue?
Well, for all of them.
Not all of the. For methylene blue, it is good, but it's not as effective as IV, especially if we nano drug methylene blue, we turn it to nanoparticle. The best way is doing it IV, and you can have it more longer in the body, more concentration in the cancer. So nano methylene blue is better, IV, but oral also work as well, but nano IV is better.
And then the ICG?
ICG can be done only IV or interstitial or intertumor, inside the tumor.
Because I got a tablet, but I'm questioning whether it actually.
ICG tablet?
I'll show you the.
Is it endocyanine green tablet?
Yes.
Okay, the problem if it's not nanoparticle, it does not last in the body longer. It's just minutes and it goes into the liver. It clears up. So you don't get the benefit of concentration of this ICG into cancer cells. So it's better to do nano and IV for ICG. Methylene blue, you can do oral, it works, but or topical as it is, but it's better to do nano for methylene blue. So only methylene blue, you can go around it and do the oral as well, but the other drugs, I don't see it's possible.
And the curcumin, the activated.
Curcumin, it can be done oral, yes, and I developed nano curcumin, that's from the United States. I have a manufacturer who developed that. But what is better? Of course, IV is better.
But if you say you do the IV
And you can, yes,
you do the
you do oral nano curcumin in between, price, affordability, and all that stuff, factors. It's better than nothing, yes. But what we're trying to do also, if we're able to do low dose of ICG and curcumin, but the patient has to stay longer, then that makes it more affordable for the patients as well. But if you do high, then you can only do once a month, once a week. It's difficult to be afforded for every day. So what we will do, we'll try to lower down the doses, but do it every day. The problem of that is that the patient has to stay 3 months, 6 months, even 1 year during those treatments. But that's the best effective way of treating cancer, is low chemotherapy, photosensitizers, and every day until we get this cancer done.
Okay, so if you say you do it every day, so you would do all the lights, would you do all the lights every day, or do you do one light?
Now I will do all the lights because I will do the combination of curcumin, doxil, ICG, and methylene blue. All of them. And I'll do all the lights. The blue, the infrared, and red. Because the blue works on both doxil and curcumin.
Okay, so you would have to do that. So I think I did a course with Dr. Fred on this machine, and I think it was 5 days, but I can't remember if we did a different activator every day, or is it?
Well, I think Dr. Fred and I will agree on coming up with the same protocol. I think it's best to do all the light because there is synergy between all of this. There's articles, publications show curcumin increases sensitivity of doxil. And of course, it will increase the Maitland dual ICG. I have publications that show the synergy between those. So I will do though, continue every day. You may take the weekends off, but in weekends you need to take some oral cancer drugs and Maitland Blue oral and curcumin. You will never stop taking anything that helps to destroy the cancer cells. Don't give breaks. Once you give the breaks, those cancer stem cells, they develop resistance and they find a way to go around your therapies. So you need to hammer it, continue hammer it, not stop. And the good thing about it, what stops the traditional, why we have the traditional cancer chemotherapy limited to 3 months and they cannot do more, or radiotherapy limited, is the reason because it can suppress the immune system. That's the reason they stop it. It's not that they don't want to continue, but if they continue, the bad side effects is more than the effect itself. But in our therapy, we don't have that side effects. We manage that by nanoparticle, by low dose, by photoactivation, so you can continue doing it until you get rid of the cancer. It is costly, yes, but we will try to lower the cost by developing it here in South Africa and make it affordable for you. Any questions?
Enigiemand nog vrae? Okay, dan gaan ons nou breek vir 'n bietjie koffie en teetjies, 'n bietjie bene.
Thank you very much.
Thank you, dokter.